All right, good morning, everyone. Welcome to the RMT convention. I was there last year live. I wish I could be live there this year. I want to thank Scott and Monica for inviting me back again. They've asked me to talk about total body balancing. Let me just bring this up right now. There we go. Now, total body balancing is a technique that I'm very passionate about. The reason being is that this seminar I'm going to talk about today, it kind of goes out to all our failed patients, the patients that didn't respond to local techniques. They didn't respond to local exercise or modalities locally. These are our patients that fell through the cracks. These are our patients that have spent thousands of dollars on therapy. These are the patients that did not respond well to surgery. They're over-medicated. These are the people that when you talk to them, they feel like their life has been lost. And one of the key reasons is that I see is that we tend to focus too specific on the problem or the area of their complaint instead of stepping back and taking a look at the bigger picture and asking different questions. How does the body heal? What are the barriers in the way? And what I'm going to try to do over these next 2 hours is to get you to think a different way. We don't want to take anything away from what you're doing already. We just want to add a different perspective, something that you can add to what you're already doing. So I'm going to talk about, let's see here. Here we go. This is sort of my presentation. I'm going to do it in 2 parts. So it's roughly going to be 2 hours, could be a little bit more, a little bit less. We'll see how it unfolds. Key thing is I want to deliver a message today so you can benefit from it. Ideally, I wish I was there live because it'll be good to show you these techniques. I'm going to show you a couple of videos, but I'll have pictures of the different techniques. In part 1, we need to talk about the total body evaluation. We need to talk about, well, how do we make a decision? How do we know that somebody actually is a total body patient, or do we work on them locally? So that all comes from the get-go. Even though I'm so passionate about total body balancing, it doesn't mean I do it on every patient. It's the evaluation that determines what it is we're going to do. So I'm going to talk about how the body heals, the pathways, that could get in the way of this healing. I'm going to give you a little bit of a case history, and then use our DAI treatment approach chart, which Scott should have sent to you. You'll have that. To make a decision. Then we'll take a little bit of a break. It's tough being on the computer so long. And then we'll get into what is TBB? Why is it important? And go through the 5 different steps of TBB. And if you're interested in learning more, we'll show you what you can do with that. So the first thing that we need to talk about is, how do tissues heal? This is critical because if you understand how tissues heal, then manual therapy is very simple. You're just trying to evaluate the barriers. And you're going to find out that we can have local barriers as well as total body barriers. So one of the things that we know, massage therapists know this, is the first thing we need is tissue motion. And this provides better physiology. So we're going to use an example of a knee. So in the body, we have 4 types of tissues. We have epithelial tissue. This makes up our skin, so the skin around the knee, but it's also the lining of our blood vessels, and it creates our cavities, the thoracic cavity and also the abdominal cavity. We also have muscles, right? We have smooth muscle, which is the middle layer, we're going to show you that later, of these blood vessels that we're talking about. So that's going to be important in the healing, and also skeletal muscle. We have cardiac muscle, but that's going to be in the heart area, which will affect this knee indirectly. We also have the nervous system. So there has to be some kind of signal from the brain down to the lumbar plexus that's going to fire these muscles that affect the knee. And then also connective tissue around the knee. So if you take a look at the knee, connective tissue is bone, it's the capsule, it's the ligaments, it's the fascia, it's the cartilage. Okay, it's all these different aspects. It's also the fat. So this connective tissue is extremely important because it's all around. Now, what's important is we need a freedom of motion between all these tissues. We have to have a functional range of motion. They have to have the space to do their job functionally, especially if they're very active, if they're an athlete. The second thing that we need is we need a supply to these four tissues. These tissues need something in order to carry out their function. The first obvious one is they need arterial supply. So blood supply to within this organ, endocrine, or body part, in this case, the knee. So how does blood get to the knee? It comes from the heart to the descending aorta, the common iliac, all the way down towards the femoral artery, popliteal artery. So you need to know the blood flow to the knee. And you can see in this little middle picture here that all the cells in around those tissues that we talked about. So each of those tissues are formed by cells. Those cells are going to need the oxygen and nutrition from this blood supply. So you can see how tissue mobility is extremely important, because if you have scarred tissue in around this area, you're not going to get the blood supply that you need to this area. The other thing we need is energy supply, okay? So I'm a doctor of oriental medicine. So energy starts in the chest. This is where it starts from. Energy is basically started by the foods you eat, by the air that you breathe, and also your kidney energy. It all comes to the chest, and then it goes down the front of your arm, the medial aspect to your hand. That goes all the way up to the head, goes down the back of your body, and then comes up the front of your body. That's how chi circulates in your body. We also need nerve supply, right? The somatic nerve supply, in this case, the lumbosacral plexus. The other thing that's important here is the autonomic nervous system, the sympathetic and the parasympathetic systems. The sympathetic system is between T1 and L2. Parasympathetic is your vagus, and S2, 3, 4 in the sacrum. So why is this so important? Something called vasomotion. If you look here at the anatomy of a artery, it's the same as a vein, also lymphatics. There's three layers to it. The inner layer is endothelial cells. The middle layer is smooth muscle. The outer layer is connective tissue. The smooth muscle is under the control of the autonomic nervous system, specifically the sympathetic. So when you are in fight or flight, what happens is blood gets diverted to your muscles for fight or flight, but it gets taken away from your organs of digestion. How does this occur? Through the smooth muscle, through the activation of the sympathetic nervous system. In the muscles for fight or flight, you get a vasodilation. In the organs of digestion, you get a vasoconstriction. Now, if you're treating a patient who's on sympathetic overload, it's going to affect their ability to get the nutrition into that area, but also get rid of waste products. So that's extremely important. So we know that tissue mobility is important, but also supply to these tissues is extremely important. This is what gives each cell in the body the tools it needs to carry out its function, mainly the Krebs system, right? Krebs cycle, creating ATP, energy. Now, we also need drainage from these four tissues. What kind of drainage are we talking about? Well, venous drainage. So we know that blood's going to come in here and it has oxygen and nutrition. So that's going to escape the capillaries. It's going to go to the cells. And let's say 30 liters were to leak out of oxygen and nutrition and fluids. Only 27 liters comes back in through the venous system. So there's some kind of a dynamic. It's all pressure gradients. There's something called colloid osmotic pressure that's inside the blood vessel, and there's also blood pressure. Now, colloid osmotic pressure wants to pull the fluid towards it. Blood pressure wants to push it away. So if you look here at the arterial end, blood pressure is greater than colloid osmotic pressure, so fluid leaks out. At the venous end, colloid osmotic pressure is greater than blood pressure, so it pulls it back in. So the venous system actually takes away more waste products than the lymphatic system. It's very interesting. So this venous system is going to take this deoxygenated blood, these internal waste products, back to the heart. And this will go to the lungs. The lungs, right, are an organ of detoxification. So you're going to breathe out carbon dioxide. When that comes back to the heart then sends it down through the descending aorta to the liver. The liver is another organ of detoxification. So there, the Kupffer cells take a look at the toxins and convert it to bile. When you have a fatty meal, your large intestine will get rid of toxins. That descending aorta goes to the renal artery, to the kidneys, and they filter things out. So your kidneys, your liver, your lungs, all organs of detoxification, and this is where the veins go. We also sweat it out too. The other area of elimination is going to be the lymphatic system. Remember I said that if 30 liters were to leak out carrying oxygen and nutrition, 27 liters is going to come out through the venous system because that gets rid of a lot of our toxicity. The other 3 liters, right, is going to go into this green part here. This is the lymphatic system. So the lymphatic system is a secondary system that brings, right, fluid back to the heart, brings this toxicity back. And the lymphatic system actually deals with larger molecules. It's much wider. Now we also, I don't like to use the word energy drainage, but there's an energy circulation to, within, and from that area. So here's all the drainage outflow from that knee that we're talking about. Now, one important theory is drainage precedes supply. So in order for that knee to receive all that nutrients, you have to get the toxicity out of there first. That's why I did a lecture pre-conference on lymphatic drainage, lymphatic balancing. So that is crucial. You should all know that. Now, as a massage therapist, if you go back to that tissue motion, I want to highlight a few things here. I'll make this a little bit bigger. Notice that the arteries, veins, and lymphatics are buried in that deep fascia. And if you take a look over in this picture here, it's a beautiful picture showing how the arteries, veins, lymphatics are on the outside of the muscle, but they're also found on the inside. Okay? So therefore, tissue mobility is extremely important for physiology. All 3 are extremely important. So now we know what tissues need, right? They need mobility, which you can provide as a massage therapist. They need supply of vital substances, but they also need drainage, and we know that drainage precedes supply. The next thing we need to look at is what are the barriers? What are the barriers that can get in the way of these, of the inflow and the outflow? Okay, so let's go back to that knee example. We have local barriers. So this is where I think the biggest problem is, the biggest disconnect, is that we tend to focus more on these local lesions. It's interesting that if a patient comes to me and they have a knee problem, the patient wants me to treat the knee, right? Because that's where they're complaining of. The doctor wants me to treat the knee. If an insurance company is paying for it, they want me to treat the knee. So everybody wants me to treat the knee. And so we have this, it's called the Cartesian theory, which is also called mechanism theory or reductionism. It's how our medical model is set up. And if you have workers' compensation, for example, they follow this to a T. If I have a workers' compensation patient that's coming to see me and they have a knee problem, I am only allowed to treat the knee if I want to get paid. If I go off on tangents to other areas that could be affecting it, they won't pay for that, because that's how the medical model thinks. If you have a shoulder problem, if you have a knee problem, why would you go anywhere else? And this is one of the reasons why we have these problems. I had one lady, she came to me, she had 10 years of headaches and neck pain. I talked about her in the video. She was from Montreal. And what happened was she was treated for 10 years with chiropractic, with massage, with acupuncture, with physical therapy. But everybody treated locally in this area. 10 years, no change. When we evaluated her with the evaluation I'm going to show you today, we evaluated her legs, arms, head and neck. We found out that she had a line of tension from her left leg pulling all the way up, and her diaphragms were restricted. Autonomic nervous system was restricted. She had had a car accident 10 years ago, and she injured that left foot very badly. She had like 4 operations. If you look at it, it's still bandaged. There's still stuff oozing out of it. Picture the patient lying in front of you. So they're in supine. You're standing at the head of the table. I'm trying to move her neck around in different positions. It doesn't want to move. The tissues are tight. So for 10 years, chiropractors forced the manipulation. People would massage this area. They would do acupuncture in this area. They'd mobilize this area. Okay. What was happening is she has scar tissue built up from the surgeries and the injury from that left foot coming all the way up. Now what's happening is when you have them lie straight and you ask her to
and
bend
you
her
ask
knee,
her to bend her knee,
all of a sudden
all
I
of a
can
sudden
move
I
that
can
neck
move
out
that
anywhere.
neck out anywhere.
Scott, we're
Scott,
getting
we're
a,
getting a,
I'm getting
I'm getting
an echo.
echo.
So what
So
happens
what
with
happens
this,
with this,
Scott, I'm getting
Scott,
an
I'm
echo.
getting an echo.
We'll try that again.
Try that again.
So with this patient, I'm standing at the head of her head, and I try to move the neck around, and there's no movement. But as soon as we bend that left knee, I can move that neck in any position, because there is a line of tension from that leg coming all the way up into that neck. I'm going to take those away. All right. Because of that line, this was creating imbalance in this head and neck. And everybody missed it. Everybody focused on this area. But all we did was work on that left leg. We did the total body balancing, tension, and within that first visit, we could see a change. So this is the key thing that we have to focus on. Is when we look, there's nothing wrong with treating a local lesion. Right? There's nothing wrong with that at all. But you have to take a look at it in perspective with everything else. What's happening to the rest of the body? So locally, we can have protective muscle spasm. Right? Locally, we can have fascial tension. Locally, we can have joint restrictions. We can have swelling. We can have energy imbalances. And this can all affect local circulation of nerves, arteries, veins, lymphatics. So yeah, if you do have local stuff, you want to work on it. But if there are total body lesions, you want to work on those first. So here's, we're going to talk about the total body lesion. So what are they? Transverse diaphragms, right? So we have the thoracic inlet, which is made up of several muscles in this area. We have the respiratory diaphragm, one large muscle, and pelvic floor, several muscles that make up the pelvic floor. So these transverse diaphragms and muscles, if they are restricted, they affect the vertical flow of all those vital structures we talked about. The nerves, the arteries, the veins, the lymphatics. So this thing is crucial. So this is going to, if they're restricted, affect the inflow, but also affect the outflow. The other thing is intercavity pressure. So if we take a look, the area of greatest negativity is your chest. This is where everything has to flow back to. Okay? Now, what's the number one killer out there? Heart disease. A lot of people, when I evaluate them, they are restricted here in their respiratory diaphragm. They are restricted in their chest. In Chinese medicine, this is your shen, this is your spirit. This is who you are. And so a lot of people have a lot of emotional stress in this area. So these cavity pressures, everything has to flow back to the heart. The abdominal area pressure has to be greater than the chest. The pelvic pressure has to be greater than the abdominal. So everything has to flow back here. There's something called Boyle's law. When we breathe in, atmospheric pressure is constant. So how do we breathe in? Boyle's law says that if you increase the volume of something, the pressure decreases. So when I breathe in, your chest expands. We increase the dimensions of your thoracic cavity. The diaphragm goes down, respiratory diaphragm, this goes up. We increase volume, pressure decreases. Therefore, we move from a high pressure to a low pressure. When we breathe out, we decrease the volume, increasing pressure. So these intercavity pressures are extremely important because they control the flow of all your vital structures that we talked about. And it's these transverse diaphragms that set up the boundaries. So now when we take a look at these transverse diaphragms, they affect all your vital structures, the arteries, the veins, the lymphatics, right? Nerve flow, energy flow. Lines of fascial tension. So when I talk about fascia, there's 4 layers of fascia. There's superficial fascia. So when I used to teach with John Barnes, he would say that if you grab an orange and you peel away the skin of the orange, you're left with that white pith. If you cut that orange in half, you see the spokes of a wheel. He would say fascia is a lot like that. We have the superficial fascia, that white pith on the outside. When you cut it in half and you see the spokes of the wheel, that's the deep fascia. Okay? And then we also have meningeal fascia, which is the fascia around the craniosacral system, and also the visceral. So here, these are from Netter Anatomy. This is an example of superficial fascia. So you can see in this picture on the left, you can see the fascia around this little vein here. And this fascia covers the whole body from head to toe. Over here, you see the superficial fascia, but right here, you see how it goes right in between and becomes deep fascia. You see, the key thing is we talked about 4 different layers, but it's all one continuous sheet of fascia. So here's the deep fascia. And we have the aponeuronic fascia that covers it all. We have the epimysium, the perimysium, and the endomysium. So if we go into here, we can have the epimysium covering the whole muscle, the perimysium and endomysium. So it's layer upon layer upon layer. And all this fascia has collagen, it's got elastin, it's got ground substance. And this ground substance has hyaluronic acid and proteoglycans. So these fibers have to be able to glide past each other. They got to be able to absorb shock. These things are found everywhere. When we take a look at the knee, for example, in white, these are all layers of fascia. So each muscle has its own layer of fascia. Why? Because no 2 muscles do the same thing. They each have their own nerve supply. And these muscles, when you're moving, have to be able to glide past each other. Okay? And you can see that this goes all the way down to the cellular level. Now, when we take a look at all the muscles in the body, what's missing in this picture is fascia. Right? What's missing here is the superficial fascia, and every one of these muscles is surrounded by fascia all the way down to the cellular level. If we take a look at this picture here in Anatomy Trains, you can see why that lady that I just talked about with the head and neck issue for 10 years, you can see this posterior chain of muscles going all the way down to her foot. So I see that all the time. This is why I'm so passionate about this, because it's missed over and over again. I've gone through my charts for the last 10 years, and I would say probably 85 to 90% of the time, you have to take a total body look at somebody. It's interfering it. And just working locally isn't enough. Now, mind you, I see, I have a lot of doctors and therapists, they send me the ones that aren't responding. So I'm seeing a lot of difficult ones. So maybe that's my own, understanding. Now, we also have meningeal fascia. We have the pia mater, the arachnoid mater, the dura mater. This surrounds the brain. This surrounds the spinal cord. It creates intracranial membranes inside the skull. So in this picture here, oops, go back. So here we have the falx cerebri, and underneath it, the falx cerebelli. This separates the left and right cortex, left and right cerebellum. Over here, we have the tentorium. That's a horizontal membrane. So in this middle picture here, you can see there's the falx cerebri. Falx cerebelli is down there, separating the 2 cerebellum, and this is the tentorium. So it basically divides your brain into 4 sections. Now, here's the key thing. If you look at this bottom picture, the dural tube, which is the outer layer fascia, it's going to attach to the foramen magnum, C2, C3, very loosely the rest of the way down through denticular ligaments. And then it's going to attach to S2. There's 5 sacral bones, and then the tip of the coccyx. There's 4 coccygeal bones. This is important. Why? Across the street, I'm in my office right now, across the street are the dentists. They send me TMJ patients, they send me headache patients, sometimes neck issues. So they come over here, and I always do a full body evaluation. They are very shocked to find out that I'm working on their sacrum, I'm working on their pelvis. And they'll go back to the dentist, and they go in there and they tell these stories about, how I'm working on their pelvis and their legs, but they came in for problems at this end. So he comes over to me and goes, Kerry, I got to ask you something. I go, what? He goes, I'm sending you TMJ patients, headache patients. What are you doing working on their pelvis? I go, are they complaining? No, they're actually doing better, but they're just confused why you're doing it. So I had to explain to him this anatomy. Now he understands. I treat him now. I treat his wife and his 2 kids, his 2 boys. And it's interesting, his son, who originally wanted to be a dentist, now wants to be a physical therapist from all this. I had another guy who was in Wales. He was my coordinator in Wales. He's a kickboxer, but he's not a very good kickboxer. He gets kicked in the face a lot. And as a result of that, he developed a lot of tension here in his hard palate, your maxilla, your vomer, your sphenoid. Remember that the sphenoid and the occiput, they come together. It's a cartilaginous joint, and there's a craniosacral rhythm. And that sacrum attaches to, the occiput attaches to the sacrum through that dural tube. So what was happening is he has low back pain. And he's asking me, hey, can you treat my lower back? And I will never do that. I used to do that before, and sometimes you get lucky. If someone comes to me and go, oh, I got this neck pain, can you see it? Or I got this back pain. I said, book an appointment. I need to take a look at your whole body. I'm not going to make those mistakes again. And he was one of those people. He said, can you just do something to my back? And he has everybody working on his back, but it's not doing anything. So I evaluate him, and his whole cranium, the hard palate, is locked up. So I go, this is where it's coming from. And he goes, he never heard of cranium. So he thought I was crazy. So I get gloves on and I start opening up his hard palate, his vomer, his sphenoid. This took care of his back pain. See, if you understand the anatomy, you can see this. It's very, very clear. And then we have the visceral fascia. So you can see here that we have fascia in the neck. All the visceral fascia kind of hangs from the occiput and goes all the way down to the pelvis. So you can see here how we have fascia around the trachea and the esophagus. So we have visceral fascia in the neck. We also have visceral fascia in the thorax. So it's around the heart, pericardium, the pleura, and also we have it in the abdominal region and also in the pelvic region. Usually 2 layers of fascia, a viscera and a parietal pleura and peritoneum. And we have a film of fluid in between. Now, the key thing is I'm mentioning all these different layers of fascia: superficial, deep, the meningeal fascia, the visceral fascia. The key thing is it's all one continuous sheet. Remember that. It's all one continuous sheet. So one of the things that I need to do when I evaluate the pathway of healing is evaluate lines of tension. What's happening in the legs? What's happening in the arms? What's happening in the head and neck? I want to feel, is this interfering with the pathway of healing? And remember this picture here, built into all this is your physiology. So if there's any fascial restrictions in there, it's affecting your pathway of healing. So this is crucial. So the transverse diaphragms, these lines of fascial tension, these could potentially be affecting arterial flow, venous return, lymphatic return, energy flow, nerve flow in the body. So you want to rule it out. And we're going to show you a quick screen today. And you can do it. If you're good, you can do it in 5 minutes. Okay? And then you're not going to make any mistakes. You do it, you're like a lawyer, you're building a case. Is this a local problem or a total body problem? So this is what we have to do. The 4th component of these pathways is the autonomic nervous system. So the sympathetic system, like I talked about, is T1 to L2. The parasympathetic is your vagus, cranial nerve 10, which comes out your jugular foramina. So it's between your temporal bone and your occipital bone. So that's why a lot of people have a forward head posture. So a lot of people are tight up there. So I'm always opening up that area. Structure affects function. Then also S2, 3, and 4. Okay, so we need to take a look at that. Now remember, this autonomic nervous system, it affects vasomotion. It affects microcirculation. If we're talking about how important physiology is, then you need to take a look at this. The autonomic nervous system is something you need to assess on every single patient. And think about right now with COVID going on. People are freaking out. People are, they're all jacked up when they're coming in. I'm opening people's diaphragms. I'm balancing the autonomic nervous system. because this is where the healing takes place. Okay, this is where the healing takes place. So when I talk about the total body barriers to this pathway, it's the transverse diaphragms. It's the lines of fascial tension. Okay, it's going to be this autonomic nervous system, which will affect vasomotion, microcirculation. So I want to give you a little bit of a case study. Okay, now this case study this was from a patient of mine he's actually a good friend now. And he was a baseball player. He was a pitcher, and he played for a University of Florida. And what happened was before I knew him, his father actually was taking him around. He spent the summer going from clinic to clinic to clinic. This is when he was trying out for the University of Florida baseball team. Okay, he's a big guy. He's like 6 foot, 6'4", 6'5". He went to physical therapists in this area. And what did the physical therapists do? Well, they did modalities. Okay, they put ultrasound, electrical stimulation, some used laser. And where did they do it? They did it on his shoulder, because that's where he was complaining of the pain. They also did range of motion exercise, but they just did them on the shoulder. They did strengthening exercise, tubing exercises, right? No changes at all in his condition. He went to a chiropractor. His dad brought him to a chiropractor. Where did they evaluate? Neck, shoulder area. They manipulated those areas. And when it wasn't working, what did they do? A lot of chiropractors have massage therapists. So they were massaging that area. Again, just treating the shoulder. Then he went to an acupuncturist. What did the acupuncturist do? Now, here's an interesting thing. When you study classical acupuncture, like I've studied classical, you look at the whole body. When you study, I would call it, westernized acupuncture, they do it the way the medical doctors do it. If you come in with a shoulder problem, they're sticking needles in the shoulder. They're creating a flow instead of looking back at the whole body. It's the same, crap that we're facing, even though it's dealing with the energy system. So all therapies work. Everything depends on where you're going to do your treatment. Okay. So no changes all summer. And these guys, I have nothing negative to say about any of these practitioners, except one thing. They were treating locally. And this was not a local problem. Okay? This was not a local problem. So I want you, if you get out this DAI, a treatment approach chart, Scott, Monica would have sent it to you. So when he came into my office, his father said he's got a right shoulder problem. Can you treat it? I go, yeah, well, let me evaluate. So I'm going to show you a total body screen right now. And with practice, you can do this in as little as 5 minutes. Okay. What we're trying to do with this total body screen is we're trying to decide, does this baseball player, does he have a local problem in his shoulder where he's complaining of? Is that where we need to work? Okay. Or does he have a total body problem affecting the pathways of healing? Okay, what's happening with this individual? So this is the DAI treatment approach, and you should have this. All right, this should have been emailed to you, and it has a nice description. This took me 30 years of clinical experience to put together. Okay, I remember sitting in my office one day, and a patient came in with low back pain. And I didn't know what to do. I had too many techniques. I could have done Maitland technique, Carlton-Bourne technique, manipulation, mobilization, myofascial release, muscle energy, strain counterstrain, craniosacral, visceral. Okay. How do you decide what to do? And do I treat locally or somewhere else? I realized that a lot of the courses that I took were treating me techniques. I don't need any more techniques. I need an effective way of evaluating to decide which modality to use. All therapies work. I have nothing negative to say about any therapy. I love learning. I've taken over 300 different techniques, and Scott told you my background. I love learning, and I still love learning. All therapies work, but the key that I'm interested in is what does this person need right now? Is it a local or is it more total body? And at that point, when I was sitting there in the office, and that's what kind of led me to osteopathic school, it led me to understand that osteopathy is not a technique, it's a philosophy. It's based on principles, it's based on anatomy. So for me, I go back to anatomy, I go back to physiology, I go back to the people that developed osteopathy, A.T. Still. Go back to the old books, you know, take some of that information and then, you know, you can update it, but just understand the essence behind it. The rule of the artery is supreme. Nobody ever explained that, but now it's very obvious. The rule of the artery is supreme. It's not just the artery, it's all that stuff. It's a physiological model. Chinese medicine is a physiological model as well, the movement of qi. They're all saying the same thing. We need movement. And what is the barrier that's in the way? A local barrier or a total body barrier? So this is the screening examination. Okay, 6 parts. And you can do it in as little as 5 minutes. Okay, first thing is a postural scan. So the first thing that you want to do, and I'm going to show you a video of this, but you want to go to the occiput. And you make, first of all, does everybody know your dominant eye? So what I want you to do is pick a spot. I'm going to pick my webcam. I'm going to put my thumb and index finger together, both eyes open. I'm going to make it small, small, small till I just see it. And I'm going to close my left eye. I still see it. I close my right eye. It's gone. So I'm right eye dominant. So I make sure that when I'm evaluating, I have both eyes open, but my right eye is right in midline. Make sure you're measuring with a straight ruler. I see people that are, you know, their fingers are all twisted. Make sure that you're always straight and make sure your eyes are exactly behind the area that you're going to evaluate. So why are we looking at this? Because if you look at this picture to the left, right in here, there's the jugular foramina. That's where that vagus nerve comes out. And look here at this middle picture, look at all the different organs that are affected by this vagus nerve. So if the occiput is off, if the temporal bones is off, structure affects function. So this is the first thing that we look at. What's happening? It should be, now, if it's lined up, right, there's no guarantee that it's okay because I'll do a mobilization later on to do a local check because you could be level, but it could be stuck. Okay, so these are screening evaluations. S2, 3, 4. So if you look down here in green, right, S2, 3, 4, there's a parasympathetic nerve supply. So these are all parasympathetic. So in blue here, this is all parasympathetic. Every organ has sympathetic and parasympathetic nerve supply. And how do we evaluate that? We place our thumbs on the sacrum, on S1. There's 5 bones that make up the sacrum. Make sure when you're behind them, you can be sitting down, make sure your dominant eye is right back there and you're checking it out. Now, the next thing we want to check is the sympathetic nervous system. That is T1 down to L2. And you can see from this picture here, this is a sympathetic chain. The sympathetic chain is found where the rib and the transverse process meet. And it's on either side. Now, L1 and 2 don't have a rib, but it's right there where they, roughly along that same line. So again, you're going to run, I like to use my thumb. Some people use 2 fingers. You're going to run them down each side using your dominant eye to see if there's any asymmetry. If the person's shirt is off, you can now, as you rub your thumbs down, you can see, is it red? That's acute. If it's blanching, that's chronic. Does it feel warm? That's acute. Does it feel cold? That's chronic. Does it feel ropey? That's chronic. Does it feel focally tender? It's more acute. So which level of involvement do we have? T1 to T6, this is the sympathetic innervation for the head and neck, you know, the eyes and that, and the heart. So if you're evaluating that area and you see asymmetries in that, that could be affecting sympathetic to the head and neck and the heart, and also the lungs. Now, T5 to T9, as we go down, is your liver, your gallbladder, your stomach, your spleen, portions of the duodenum and pancreas. This is very accurate. A lot of the old osteopaths would just run their fingers down, and that's how they would do their visceral evaluation. T9 to T12 is the rest of the duodenum and pancreas, the rest of the small intestine, the ascending 2/3 of the transverse colon, right? And then T12 to L2 is the rest of it. The rest of the transverse, descending, your rectum, but your kidney, your bladder, your uterus. It's very accurate, right? Now, the other thing we check in this postural evaluation is T-lines. So I'm going to place my hands like this on your shoulders and also on your pelvis. What this quickly tells me is lines of fascial tension coming up through the arms or the legs. And we just looked at the head and neck into the body. So it's a very quick scan. So here is our postural scan: occiput, sacrum, spine, upper and lower T-line. What I'm going to do now, this is about 4 minutes, is I'm going to show you a little video here. All right, we're going to start with the total body screening examination. The first part is going to be in standing, the postural scan. This is a quick scan that we can scan the autonomic nervous system as well as lines of tension. So I'm going to palpate the occiput, so right in here. I'm going to palpate the inferior ridge of it. The reason why I want to palpate that is because structure affects function. We have the vagus nerve, cranial nerve 10, which is going to come out the jugular foramen on the left and right side. That foramen is formed by your temporal bones and your occipital bone. So I want to come in here and palpate that. Now, one of the things you have to be aware of is your dominant eye. So one of the dominant eye tests is you put your hand together like this, you look through it, pick an object, and then you want to close one eye and then the other eye to see which eye is more dominant, which is lining it up better. I'm more right eye dominant. So I want to come in here and make sure you measure with a straight ruler. So I'm trying to get out of your way for the camera, but I come in like this and I measure to see which one is higher. Now, we will do other tests in various classes where we actually do tension tests and feel the musculature. This is a quick screening examination. If this occiput is not leveled, it tells us there's a potential to have a problem with the autonomic nervous system, the parasympathetic system here with cranial nerve 10. The other part of the parasympathetic system is the sacrum, S2, 3, and 4. And what we're going to do is we're going to measure the sacral base, S1. So I'm going to come in here. I'm going to palpate really at crest. I come down, feel the PSIS, come in and up about 1 centimeter. And again, I'm feeling to see if that sacral base is unlevel. I want to make sure my dominant eye, my right eye, is lined up. I would be behind her more, but I'm trying to get this so you can see it. So this is our parasympathetic. The sympathetic is from T1 down to L2. So what I'm going to do here is I'm going to palpate right here where the transverse processes are. Where the rib comes into the transverse process is where the sympathetic chain is. So what I'm going to do is I'm going to start here at T1, and I like to, some people like to do this, where they place their fingers on either side and they kind of run it down like this. You can do that, but I actually like to use my thumbs, get my dominant eye in there, and I actually will come back down and begin to feel those different levels. You can do this with someone's shirt on, and I can be aware of the levels like T1 to T6 is your heart and lungs, T5 to T9 is your liver, your gallbladder, your stomach, spleen, portions of the duodenum and pancreas, etc. as we go down, so it's in your manual. Now, if her shirt was off, we had a gown on it, as I run my fingers down, I could pay attention to see what color is there. If it's red, it's more acute. If it's more white, kind of blanching, it's more chronic. Does it feel moist? Moist is more acute. Does it feel dry? Dry is more chronic. Does it feel focally tender? That's more acute. Does it feel more ropey or spread out? That's more chronic. So we have parasympathetic, parasympathetic, sympathetic from T1 down to L2. Now L1 and 2 don't have ribs, but I can still feel the paraspinals. The next thing I want to feel, we call these the T-lines. So if the spine was like this is the upper T-line, this is the lower T-line. So I want to come up here and again get my eyes at that level, and I want to feel the level of the upper T-line. This indicates lines of tension coming in from the arms into the axial skeleton. I can also come down here and I can palpate the iliac crest. This is the lower T-line, get my dominant eye in there. And again, this tells me very quickly are there any lines of tension from the lower extremities coming into this axial skeleton? Now, we're going to confirm this by lying her down and checking her legs or arm. We'll also check her head and neck in the next series of tests. All right, so that's the postural scan. Now we got to take a look at the lower extremities. So I can pick up a leg and I can feel the weight of a leg. Now, they should both feel the same, but a lot of times you'll feel that one leg feels heavier than the other. So why? More congestion. Whichever leg is lighter, that's the leg I'm going to start with. I want to use it as a measurement, a comparison. So what I'm going to do is I'm going to take the foot, place it in my belly, and I'm going to do what we call a leg pump. I'm going to compress up through the system. I'm going to see how does the body receive that. Now, if I do it on the other side, which is heavier, what you might find is that there's an abrupt stop, right? It doesn't like that pressure. There's congestion there. The other thing I'll do is a leg vector, where I'll pick up that leg and I'll work on a circumduction, either clockwise, counterclockwise. I'll do the lighter leg and then I'll do the heavier leg. So I'm assessing for lines of tension coming up through the legs into that trunk, affecting these pathways of healing. We can also evaluate the upper extremity. In the upper extremity, I can feel the weight of the arms. Whichever arm is lighter, that's the side I'm going to start with. The same thing I did with the legs, I can do an arm pump. So I can support the arm with one hand above and below the elbow and compress up towards the head and then distract. And I can also do an arm vector. I can do that clockwise and counterclockwise to assess any tension in the arms coming into the trunk. The other area is the head and neck. Okay? So I want to assess tension. Remember the meningeal, remember the visceral stuff here. What's happening in this area? So I can pick up and feel the weight of the head, and I can do a rotation, a vector to the left and to the right to assess any tension in this area. So I'm going to show you another little video on this. All right, I'm going to continue with the total body screening examination. So we've already done the posture evaluation and standing. We're going to check lines of tension in the legs, the arms, and the head and neck, and how they influence the torso. So I like to start with the legs. And what I do is I pick up one leg and then the other leg. I'm looking to see which leg is lighter, which leg is heavier. This leg is lighter. So I'm going to come in here and place the foot in my belly. And I'm going to gently compress in through the body. How far can I go? Typically, you like to be able to go all the way to the head. You pause, and then you distract. When you distract, you're evaluating lines of tension. When you're compressing, you're evaluating congestion, more of a fluid model. And then I can support her leg and evaluate sort of a circumduction, a leg vector. I can do clockwise or counterclockwise. I'm just feeling any lines of tension into her torso. I come to this side, feel the weight. This side's heavier, so that's a limb weight test. Place it into my belly, I compress. You can see the difference. I can't go as far. So she's got some compression there. And then if I try to distract, there's a problem there as well. When I come in here, right away, this is as far as I go. So she actually has an issue with this hip. You can see it's much smaller motions. Remember, this side was much bigger. So she has something going on here. As I come up, I'm going to check the arms. So I can feel the weight of the arm. Come over here, feel the weight. And again, I would go to the lighter arm. I'm going to stay just on this side just because of the camera. But you do the same thing. Do the lighter arm, then do the heavier arm. It just helps you feel the difference. So I pick this up, and I'm going to support her above and below the elbow, like this. And I'm going to compress upwards. And this is the compression test. So you're testing for any type of fluid. And then I can distract. That's lines of tension. With her palm up, I can do the arm vector, and I can feel for any lines of tension. And I can go counterclockwise or clockwise. So I'm feeling for lines of tension coming into her torso. And I would compare that to the other side. Now I come to the head. I feel the weight of the head. And again, that tells me congestion. Okay? And I can do a sort of a head-neck vector where I can flex her up till I feel the tension, and then I can rotate her in one direction, pause, and she has a difference there. You can see she likes to go this way, and she doesn't like to go that way. So those are all the lines of tension in the legs, the arms, and the head and neck. Okay, now we want to take a look at the thorax. Now the thorax is very important. I have the patient cross their arms and I'm going to rotate them to the left and to the right. So that is going to evaluate the thoracic inlet. That's going to evaluate lines of tension coming in from the arms and the head and neck to this area. This area is so important because if you took my lymphatic class, the one we did pre-conference, everything flows back to this area before it goes to the heart. It's also where the autonomic nervous system, specifically the sympathetic nervous system. So one quick test here gives me a lot of good information. The other thing is remember that everything flows back to the heart. So I'm going to place my hands on the sternum and I'm going to do a sternal pump. Because remember what I'm trying to find out, and I'm trying to find out, is this a fluid model or is this a orthopedic model? Lower thoracic rotation, I can come in right around where the lower ribs are, where the respiratory diaphragm is, and I can rotate that to the left and to the right. This will help me evaluate the respiratory diaphragm, but also lines of tension, and also the autonomic nervous system, the sympathetic nervous system in that area. I can also go down into the pelvis. Now, if you take a look at this picture off to the left here, I would have gone over this in that lymphatic course, which is a pre-conference course. So remember that everything below your belly button, like your lower abdominal muscles, your lower back, your sacrum, your pelvis, your thighs, knees, lower leg, ankle, feet, etc., everything drains to the groin. From there, remember, it drains into the left and the right lumbar trunk. Over here is the intestinal trunk. So all the organs are going to drain in as well. And they all meet here, which is cisterna chyli. So this is the respiratory diaphragm. This is crucial. So if I evaluate you and you're stuck in your respiratory diaphragm, I'm thinking you could possibly be all locked up through your lymphatic system. So this is why I would place my hand right here in the middle of all this. So if you feel your xiphoid process, feel your belly button, come down just below between those two, I'll do a compression and a scoop towards the head. I want to feel what's happening. And I've done this on thousands of people. So with practice, you're going to feel, oh yeah, this is good. No, you're all blocked up. So if you got tension up here, if you got tension in the sternum, remember everything is going to flow here to the heart and you're locked in this respiratory diaphragm and the abdomen. We know that you're probably locked up in your lymphatic system. We can also evaluate doing a pelvic rotation. This is going to check out lines of tension from the legs coming up, but also the pelvic floor. Okay? I'll do another video here. All right, we're going to continue with the total body screen examination by evaluating the chest region, or thorax, and also the abdomen. So I can get my patient to cross her arms like this, so at 90 degrees. And what I want to do is I come in like this. So I like to stand at the head, or you could also stand at the side. And I'm going to have one hand underneath and one hand on top, and I'm going to rotate her body in one direction, pause to the first sign of resistance, and then go the other way. You can see that she doesn't like to go this way. She likes to go that way. So what am I testing here? I'm testing the thoracic inlet, right? The diaphragm here. I'm also checking any lines of tension that could be coming in, from the arms or the head and neck, sternum into this area. I could also be checking the autonomic nervous system, so the upper thoracic region, okay? So arms by your side. I'm going to come in here to the angle of Louis, there on the second rib, place my hand there, one hand on top. My elbows are straight. I'm leaning into the table. I'm going to gently compress in. So I'm doing a compression of the sternum, kind of posterior and inferior. Behind it is the heart. So the reason why I'm checking this is because lymphatically, everything is going to flow back to the heart. In the lymphatic system, the fluid is going to drain from a high to a low pressure. If all this is blocked up, you're not going to get good circulation. So I'm seeing, is there a problem there? I'm going to come down here, and I'm going to check this region, these lower ribs. I'm going to place my hand on either side. And what I'm going to do is I'm going to rotate, it's like a steering wheel, rotate everything in one direction, pause, and then come the other. She doesn't like to come this way. She likes to go that way. So what am I checking here? The respiratory diaphragm. This is a key area because all the drainage has to come through here, to come here and then back to the heart. I'm also checking lines of tension in that area, and I'm checking also the rest of the ANS from T1 down to L2, the lower part of that. And when I come down into her belly, we know that everything below the belly button, superficially, So the lumbar spine, the sacrum, the pelvis, both lower extremities are going to drain into the groin. They come together in the left and right lumbar trunk. They meet at sternocleidomastoid. They go through this diaphragm, the respiratory diaphragm, and come up here into the heart. So here I want to feel the xiphoid process, the umbilicus. Place my hand here. I'm going to gently compress and scoop upwards. So normally I should be able to sink my hand in quite far, but if I feel a lot of bogginess, this just tells me that this is all blocked up. And if I felt a lot of heaviness in the legs, especially with a compression test, it's telling me there's problems here. So this is a really good scan to tell me that, you know, you're trying to be a lawyer, you're trying to build a case, you're trying to, you know, evaluate as many things as you can. And if there's lots of tension, it tells you it's more of a total body problem. And if you're only finding a few areas, then it's directing you more to a local body. Now, if it's a total body problem, is it more something for TBB, total body balancing, where it's more lines of tension, more of an orthopedic model, which is like the skyscraper principle? You know, the head is the penthouse, so we clear things from the bottom up. Or is it more to do with a fluid-based model? Okay, total body lymphatic balancing. So if it's more of a fluid model, we can't start at the feet and work our way up, because that's going to block out the whole system. We actually have to start here and work our way out. So it's a big difference. So I want to get an idea with these patients, you know, is this lines of tension or is it more congestion? So when I picked up the legs and I'm, you know, compressing them, is it more congestion? The arms, more congestion. Do I feel things blocked up here, and do I feel a lot of congestion in these areas? The next area I want to check is this pelvic area. So with my hands on each side, I'm going to rotate her pelvis to the left, pause, and now rotate it to the right, and you can see that she moves much easier to the left than the right. So this is checking the pelvic floor. It's checking sort of lines of tension. It's also checking the autonomic nervous system, S2, 3, and 4 for tension. So once again, this is the end. It's a quick screen. Remember, it's not a detailed evaluation. It's a quick screen, and it's telling us whether this person is a total body or a local body patient. Okay? So this is the total body screening evaluation. 6 components. Looking at the posture, looking at lines of tension in the lower extremity, upper extremity, head and neck, and then finally checking the thorax and the abdomen. With practice, you can do it in as little as 5 minutes. Now, if the patient doesn't meet the criteria for a total body approach, that means that it's more of a local issue. Okay, it's more of a local problem. Now, with this individual, we need to do art. So if this, baseball player came in and I'm checking, transverse diaphragms, lines of tension, autonomic nervous system, all these different things, and if he doesn't have any of these problems, then I'm going to do a local evaluation. So what's my local evaluation? The best way to remember it is think of ARTS. People, when I watch students evaluate, they're all over the place. Just remember ARTS. Put your hands on the area that you want to evaluate. In this case, it's the shoulder. Make sure your dominant eye is there. Is there any asymmetry? You can look at the different planes, the transverse plane, the frontal plane. Okay? So check the different planes to see what's happening, because structure affects function. If you stand there right now, just lift your arm up, make sure you're in good alignment, and then bring your shoulder forwards, right, in protraction. Now try to lift it up. You can't. Structure affects function. This is why asymmetry is so important, but it doesn't tell you what the problem is. It just tells you that there is a problem. So we go on to R. R is range of motion. So if it's a shoulder, we evaluate the range of motion of the shoulder. And you always do active first and then passive. And you always do the unaffected side, then the affected. So if he has a right shoulder problem, I'm having him lift the left arm, and we're doing an active, then passive, and then we come to the right arm. Now we want to feel, what does it feel like? So on his right shoulder, he's getting stuck here. What does that feel like? That's called an end feel. If it's a hard, abrupt end feel, that's more joint. If it's a soft and boggy end feel, that's more swelling. If it's a firm end feel with some elasticity, that's more muscle, it's more fascia. So range of motion now gives us some more information. T, we have 3 things under T. We can palpate all the muscles of the shoulder, right? And if they're tender, we use a scale from 0 to 10. If they're like 8, 9, 10 out of 10 with a jump sign, that's protective muscle spasm. T stands for tissue texture changes. I can go in and begin to feel, always do the unaffected side, then affected, and I'm feeling for bogginess. I'm feeling for temperature difference, tension in the area. T also stands for tension tests. So what are the joints that make up the shoulder? Sternoclavicular, acromioclavicular, scapulothoracic, glenohumeral. So you can do a little spring test. Normally they should be soft and supple. They should have movement. But if they're hard and rigid, if there's a resistance, you may have a joint problem. So the T's tell you that. Special tests. We can do a fascial glide test where you compress into the barrier. We can glide up or down, left or right, or diagonals. So a fascial glide, what's happening there? The limb weight tests, right? That tells us about congestion. Proximal node tests are really important. You know, we talked about this in my lymphatic classes. So we check the inguinal nodes behind the knee, the axilla, supraclavicular, at the elbow. So where's the proximal node to the area of involvement? So with a shoulder, where's the proximal node? The axilla, and also the supraclavicular. So let's look at a situation here. If this was a local problem, so if this guy came to me and I did a screening examination, remember you're a lawyer, you're building a case. He did not meet the criteria for total body balancing. He met the criteria for a local treatment. All right, so what do? I find that people use their favorite form of treatment instead of evaluating. So how would I know that this is a muscle problem? Well, he has asymmetry, we know that. Range of motion is reduced, active and passively, but there is a firm end feel. Well, firm end feel could be muscle or fascia. So we got to continue with a T. The tenderness is the key finding. So when I do the tenderness, he has like an 8, 9, 10 out of 10, then you know you have a problem in that area. So that tells me I would need to treat his muscles there. Now, how would I know it's fascia? Same thing, he has an asymmetry. Decreased range of motion, it's firm. So again, is this tenderness? No, wasn't much tenderness there. The key finding was fascial glide. So this is how I make my decisions. Now, what if it's a joint? Well, I'm going to have asymmetry. There's decreased range of motion, but it's a hard end feel. And when I evaluate the tension test, that's my key finding. So I know it's a joint. But you can have combinations of these as well. How do I know something is swelling? There's going to be asymmetry. There's decreased range of motion, but it's a soft end feel. Okay. There's increased tissue texture changes. When I go to lift the arm, there's a limb weight difference. It's heavier on that side. The proximal nodes are affected. So the body leaves clues. Okay. Now, if the patient does meet the criteria, which this guy did, his diaphragms were restricted. He had lines of tension in both legs and that arm and the head and neck, and his autonomic nervous system was affected. So if he does meet the criteria, then we need to take a look at the left side of that chart. So it could be total body balancing, which is a orthopedic model, skyscraper principle, meaning that if your head was off or shoulder was off, we have to make sure we balance you from the bottom up. You know, if the penthouse is off, you got to check the foundation. So we work from the bottom up. LBTB is limb balancing total body. That means that you have swelling throughout the body. We can't start at the feet because fluid moves from a high to a low pressure. Everything has to flow back to the heart. So we have to start here and work our way out. So limb balancing total body and total body balancing are opposite each other. They're still total body, but where we start is very different. And I also have energetic balancing, total body. So for this individual, we have to look at all these factors. If he met the criteria, I needed to find out, was he a fluid-based model or is he orthopedic? He was an orthopedic model. So he met the criteria for a total body balancing. So all summer he wasted it because everybody was treating locally. His body wasn't set up. The pathways of healing were not set up for that shoulder to improve. We're going to take a little break. And I'm going to set a little timer here just for 5 minutes. Let me get my little stopwatch here, right there. 5 minutes. Just so you go to the bathroom, grab a drink of water, and then I'm going to start back again. Okay, 5 minutes, and then I'll be back.
And they're going to see you too. Okay? 3, 2, 1, go.
Hey everyone, how's everyone doing? Just send me a little text to see that everybody's doing okay. Or maybe you're all having a little short, quick break for yourselves. Again, I want to remind everyone to, when you're coming back in, please have your video turned off and you are all muted. We're so happy to have you here. I want you to check out the exhibitor booths. They're all standing by waiting to have a little chat. So go back into your lobby, go into the exhibitor booths and start chatting with your exhibitors. Today we've got Miss Conchita. Where's Conchita? Right here. Hey Conchita, from Vitality Depot. So she's here, ready to speak to you all. We've got Mark Chialoy, he's live here in the house. Miss Margaret Wallace-Duffy, she's here. She's going to be moderating the next opening session. So we're really, there she is. Say hi, everybody. So we're all looking forward to having a great day. We were able to get the gamification going. So for your prizes, we're going to make it a little bit more fun. I got Cindy here helping me out here with gamification. So if you have any questions, I think y'all have been seeing Cindy popping up in the chat area. But you got to start looking, you got to start engaging in the exhibitor booths and the session profiles or the speaker profiles to find those codes, those scavenger hunt codes. And once you get those codes, you type them in and it gets you points. And those points will get you into a raffle, and that raffle is going to get you some prizes. So have some fun with it. Our exhibitors and our sponsors, we want to thank them all. They've been so generous. Our global sponsor is Massage Addict. Check them out, check out their booth. They got some prizes going on inside their booth. Vitality Depot, Hand and Stone, Better Together is one, the Learning Academy. We got James coming up pretty soon. So we have any chat going on there, Cindy? Because I don't have my chat room going. Yeah. Maybe we can take some questions. Is there any questions?
People are asking for the email with the resources Kerry was showing. There are files posted.
Yeah, the files should be inside inside the sessions.
In the files section.
Yeah, in the files section. So when you're actually in the session, you just got to scroll down, and there's a files tab, and then there's 3 files sitting there that you should be able to download, no problem. Is there any other questions there? No. Nobody wants to speak with me? Come on, you guys. Any questions? Time to do it now. They might all be in the booths looking for doing their little scavenger hunts. All right. So what else we got going on? Hey, Vitality Depot, what do we got for prizes today?
Oh, we'll be giving away some analgesics, some PPE, some sanitizers.
Yay!
A whole variety of things that you're going to need every day to run your practice.
Amazing. Amazing. And I think we're having some courses being given away. Hey, Better Together?
Better Together is one is giving away a course thanks to James Waslewski.
Yay, James Waslewski. So get your points, get your scavenger hunt. Oh, I think Kerry's
Did I hear
back.
James Waslewski, his name?
Waslewski.
He's always getting in on my turf here.
Waslewski. Kerry's got some stuff hidden in his profile too. I don't know if anyone's found it yet. Hey? Just having a little gamification going. All right, let's take you back to Scooter and Kerry. Kerry, amazing work as always. Everybody, back to your desk.
I'm looking forward to watching James. He's always a great presenter. All right, so the second half here. So we taught, for me, the most important part, remember I said that, I'm tired of learning techniques. I want to learn evaluation. I want to learn what to do. So the first part we spent, how do we make the decision? That's the key point. So now let's talk about this. This baseball player, this pitcher, he met the criteria for a total body because he had lines of tension in his legs, his right arm, also all his diaphragms were restricted, and his autonomic nervous system. And it was interesting, his father still wanted me to work on his right shoulder. Right? And I'm doing all this stuff. And I purposely did not touch his right shoulder. I worked everything else, and then we looked at it, and to be continued. To keep a little suspense, what happened to him. So what is total body balancing? Well, this is my teacher here. This is John Wernham. And he's an osteopath, and he's in Maidstone, England. He studied under John Martin Littlejohn, who studied under A.T. Still. And what he thought is he thought that a lot of the students that he was teaching were missing things, just like I find. They were treating very localized. So if you came in with a shoulder problem or a neck problem or a knee problem, everybody went to that area and did manipulations. They did whatever technique on that area. And he thought they're getting away from the principles of osteopathy. The rule of the artery is supreme, the physiology. So he said, you know what? We need to set up a system so they don't miss anything. And he had something called the body adjustment. So he was my teacher. So I took the body adjustment and made some changes to it, added some things to it, and now we call it total body balancing. But everything, he gets the credit. So in our total body balancing series, we're teaching you a screening examination. We're teaching you, that's just a quick evaluation, right? It's 5 minutes. But we also teach you a total body evaluation where we check everything in more detail. I love evaluating. I think the first time you see someone, get as much as you can, get it down in their file so you can measure the change. I see my patients over many years. You can always go back and see how they've changed. Also, this is a 5-phase treatment. We're using long levers, and we are treating in the supine position, the prone, side lying, and sitting. Now, I know some of you are saying, well, my patient can't get in those. I know. This is level 1, TBB1 is the fundamental class. This is like, this is the best what we would want to do, treating in all these positions. But if you can't, that's why we have TBB2 and 3, which we'll talk about. We can get in other positions. So this total body balancing is going to treat that whole musculoskeletal system. Okay? It's going to improve tissue mobility in those lines of tension from the legs, the arms, the head and neck. It's going to open up these transverse diaphragms. Therefore, it's going to improve circulation, arterial flow, venous return, lymphatic return, energy flow, nerve flow. These are all the important things. And also, it's going to affect vasomotion. What's important is that when you do this technique, you think of a baby. If you hold a baby in your arms, rocking a baby to sleep, or if you see a wave coming in, that's what you want. It's the rhythm you want, kind of a 1, 2, 3, and relax, 2, 3. You want to give the body a dose of CTHD, calm the hell down. You want to calm this nervous system down. So the rhythm is extremely important. Now, in total body balancing, there's 3 key things. We talk about the wedge, the lever, and the screw. These are classical terms that I want to talk about. When you understand this, you'll understand TBB. The wedge is where you palpate. Okay, that's your sensory hand. So whatever it is you're trying to treat, and as we go through and we're going to show you the treatment positions, that is your wedge hand or your sensory hand. That wedge hand can be passive, meaning it can just be there, and then you're going to have a motor hand, which is going to be more active, or it can also be active. I like it to be active. I'm feeling, but I'm also doing something with both hands. Now, here's the key thing. This wedge hand, the sensory hand, as soon as it perceives change, you move on to the next area. A lot of times we tend to overtreat. So you have to get good at perceiving change. Lever. A lever can be anything. It can be your legs. You can see these pictures. It can be your arm. It can be your head and neck. It can be the spine. So for example, if I'm trying to mobilize this sternoclavicular joint, I can use my arm as a lever. I can use my neck as a lever. I can use my thoracic spine as a lever. I could even use my legs as a lever. So a lever, you pick the best lever that's going to influence that particular area. Now, here's a key thing. Your sensory hand, now your motor hand is going to guide the lever. So you want to make sure that your sensory hand, your motor hand are connected right there at that feather barrier. Feather barrier is the first sign of resistance. So you always want to stay in this line of communication, and you're feeling, you're kind of teasing it out. John Wernham would always say it's the lines, focus on the lines of fascial tension as they work their way up through the body. The screw is the osteoarticular motion. If you ever see my video, it's always gentle rhythmic motion. I'm listening with my hands, right? I'm always feeling, dialoguing with my hands, feeling where that line of tension is, using my sensory hand, using my motor hand, and doing this osteoarticular motion at the feather barrier, constantly feeling a line of communication between my hands and this is the screw. So wedge, lever, screw. Those are classical terms. So why is TBB important? Well, basically it gets you back to health and homeostasis. It gets you back in balance into optimal physiology. How does it do that? Well, it balances tissue motion. Remember all the tissues that we talked about, the 4 types of tissue. It balances structure, okay? And when it does that, it's going to improve what? Inflow, arterial flow, right? Energy flow, nerve flow, outflow, venous return, lymphatic return, energy flow. It's also going to affect, all these different things because you've removed, right, the soft tissue interference, the barrier. It's going to release all the layers of fascia, the superficial, the deep, the meningeal, the visceral fascia, which is all one continuous sheet, okay? So you're feeling for all these. And if you do it in a very gentle, rhythmic way, you're going to balance the autonomic nervous system. And this will also open up the diaphragms. Now, if you can balance transverse diaphragms, if you can release lines of tension, if you can balance the autonomic nervous system, remember that we are treating an intelligent body. AT still would say, and nature will kindly do the rest, okay? The body heals itself. All we're doing is creating a better environment for healing. And that's what we're doing, creating a new, balanced, homeodynamic state. And we want these people going away with functional range of motion, being able to return to work, their sport, right? Anything they do, okay? So there's 5 phases. Now, I wish, I just finished teaching a class online, a manual therapy class, and we were able to do it. It rocked. We had good feedback from it. We had about 8 TAs, and each TA had 4 students. And we would make sure that the webcam was focused, or you would do that on the table, and you would have someone to work on. So I would lecture, I would demonstrate through video, and then we would, at the end, we would do the workshop. So you would have somebody at home or somebody come over just for that last hour. And how we did this class was really cool, is we did them in 4-hour increments, okay? And we could do it slowly over a 2-week period. And so you just, small portion of your time, maybe at the end of the day, and you get through this. So this is something, if you're interested, let Scott, Monica know, we could actually do this as a live class. Now, if you're interested in this total body, what I'm going to show you, because I'm going to kind of go through this. This is an introductory. This is TBB1. Everything I'm doing is from TBB1, Total Body Balancing 1. This is our fundamental class. This is going to go through the supine, the prone, the side lying on the left and right, and the sitting position. Okay? Now, when the patient is lying down, I'm going to be starting on their right side. I'm going to pick up their leg, and I'm going to do these leg vectors. I'm going to do these leg pumps, and also the leg vector with the knee bent. What I'm trying to do is I'm trying to release lines of tension in that right leg as it comes up through the body. I'm trying to tease out the diaphragms. I'm also trying to affect that whole dural tube. So as I line it up, you can see the patient's head moving up and down as you're working on them. So we call this preparation, because you're just trying to release general lines of tension, because I'm not really palpating anything here. Both my hands are on the limb, so I call it preparation. You're just doing a general release. But if you line up a certain way, you can be very specific with your tension. There's something called the bowstring theory. So you see in this first picture, you see the shaft of the bow represents your spine. The string in the front is going to represent your organs and the diaphragm. So a lot of people, when they come in with neck pain or back pain, they're quick to go to those areas, but you want to check the string first. The string is the diaphragms, and it's the organ system, because if the string is too taut, the shaft of the bow is going to be restricted. This is why we treat in the supine position first. We would never put somebody face down first. So in this position here, this is a leg roll, and my left hand is actually right here, right in here in this SI joint, but on the right side. And I'm opening up that particular area. I'm opening up that SI joint. But also, as I'm doing this, I call it total body balancing because, the old osteopaths, they did things inclusive. So if I'm moving this leg around, I'm working on the muscles and the fascia of the leg, But because of the interconnection of fascia, I'm also working on the dural tube. Depending on how I'm doing it, I'm releasing lines of tension up that leg. I'm affecting the diaphragm. I'm also a lymphatic pump. I'm working on a lymphatic pump in that right groin. So you're doing lots of different things. That's why I call it total body balancing. And remember, TBB is an orthopedic model, skyscraper principle. We start at the legs and we're going to gradually work our way up. Once I finish that, I have my hands above and below and I'm doing a nice little integration. And I tend to do this just to kind of calm the body down, right? Calm the autonomic nervous system down. And then I leave that leg in a nice position. The next thing I want to do is evaluate that arm. And I'm going to do an arm vector. I'm going to start just like we did the preparation in the lower legs. I'm going to do it here in the upper extremity. So preparation here, I'm releasing lines of tension in this arm as it comes into the trunk. This will also affect the nervous system. It'll affect the dural tube. It'll affect, in this area, that thoracic inlet, that diaphragm. And then I start to work the upper extremities. I have 3 positions that I use. I use the arm straight up like this. I use it at an angle, which is this one here. And so this is going straight up and down. This is at an angle. And then this one here is more of an internal rotation movement. So I'm using this lever 3 different ways. Now the question would be, well, how do you know which one to use? Well, I kind of, you experiment with all of them because you have a sensory hand, and that sensory hand, my right hand is sensory in this case, it's going to be palpating this thoracic inlet. Look at this picture at the bottom here. This is where all the lymphatics go back to. If you took my pre-course, you'd be aware of all that area. So I try to open up this thoracic inlet. I open up the clavicles, ribs 1 and 2, that's thoracic inlet. But also my right hand will gradually start to work my way down the front of the rib cage. I'm working on that bowstring. So as I work with this right arm, I'm releasing lines of tension in the right arm, but I'm also opening up the rib cage, opening up the diaphragms, opening up this thoracic inlet, improving circulation into that area. I continue working on the ribs. We do a pump handle motion. Now, when you breathe in, you should feel this motion that comes up in front. That's called pump handle. So if you were to do this action here, that raises the ribs anteriorly. If you were to do it this way, this raises the ribs laterally. So you can see this top picture is more pump handle. And my left hand is now sensory. That sensory hand, it can be passive, but I make it active. I want to make sure that I feel a line of tension between both hands. So I'm trying to open up that bowstring. And then this bottom picture here is I'm opening up the ribs on the side. So this will open up the ribs, but it'll also open up the diaphragms. Okay? So it's going to release those lines of tension. Then I start to work my way down the arms. I want to release the wrists. I want to release the elbows. I want to release any remaining line of tension in this area and finish with a nice little stretch. So what we've done so far is we've opened up the right leg and pelvis. We've started to open up the thorax. We've started to open up the right arm. And then what we do is we do the same thing to the left side of the body, right? The same preparation that I talked about. Now, here's the one difference here. So notice over here, I'm on this side, notice I'm coming across the body. What happens is if you watch my hands, typically what we find is the right innominate goes anterior and the left one goes posterior. And as a result, the sacrum goes to the left. So everything is moving to that left. So what we're trying to do here is reorganize that pelvis and sacrum. So that's why on the right side, we went into flexion, abduction, external rotation. But on this side, we're doing flexion, adduction, internal rotation. So both hips are going to the right. Okay, both legs are going to the right. And I'm still palpating at that SI joint. Still releasing the pelvis on that side, the joint, still creating changes up the dural tube and releasing lines of tension. So that'll be the only difference. And then I'll do the nice little integration, a little dose of CTHD, calming everything down, the autonomic nervous system. Then I go to the left arm, right? I do that left vector, preparation, releasing any lines of tension on that left side. And then we do the 3 arm movements on that side, okay? We want to open all those up. And this will help to just get everything flowing. And remember from the lymphatic lecture I did, this left side actually drains 3/4 of the body. So this left side is so important to open up. I'm also going to open up the ribs on the left side. Everything I did to the right side, I'm going to do to the left side. So we started with the right leg, worked our way up, opened up the right chest, the right arm. Then we came up the left leg, left arm, and left chest. So here we are working with the left arm. So now we've worked everything there, except what? We haven't really worked this area yet. So what I want to do is I want to make sure that I start to work on the clavicles and ribs 1 and 2, because this area, this thoracic inlet, is so important, because this is where all the lymphatic drainage, venous return, all come back to this area before they go to the heart. So this is crucial, okay? So one of the things that I'm going to do is I'm going to work flexion and extension. Now notice, I want you to pay attention to the anatomy here of these facets. There's 3 joints typically in your lower cervical spine. We have a disc, which sits between the vertebral body. That's a cartilaginous joint. And then we have 2 facet joints on either side. Those are synovial joints. Notice that they're angled like this, okay? The other thing I want you to pay attention to is notice how this is saddle shaped. As we get older and we experience less fluid in the disc, we can get bone-on-bone contact here. We call that joint of von Luschka. So with elderly people, you got to be careful about side bending. So because of the nature of these facets, this is important. When I'm standing at the head of the table, and if you look at this picture here, notice where my hands are. So what I'm doing is I'm going to lift towards the nose. I'm going to lift towards the nose, which will glide along these. I want to take the joints out of the equation, because all I really care about is releasing lines of tension from the head down into the trunk. So that's why I lift. I use my hands are relaxed. I'm using my legs. My elbows are straight. Okay? And then I can begin to very gently oscillate and work side bending, just gliding up and down. But you need to be careful with that if you're with elderly people, because of that joint of von Luschka. And then I can work with rotation, and at the end, I can get a nice little stretch in the upper fibers of trapezius. That's how I kind of end it in the cervical spine. So that's the supine phase. Supine phase, I want to release lines of tension in the legs, the arms, the head and neck. I want to open up this bowstring in the front. Now I can safely put you on your stomach, because I've opened up the bowstring. If I would have started with this, like if somebody came in and they're all flexed forwards and you try to put them on their stomach, you're not going to do anything. Everything is all jacked up. So this is why we do supine first. In prone, I'm going to place both feet in my belly, and I'm going to do a nice leg pump. Okay. And I start off, it's a bilateral leg pump, is I want to start to get the lymphatics going in both legs coming up through the body. So this is kind of a preparation in the prone position. Then in this top picture here, I'm going to start working with the foot. I'm going to start to work with any lines of tension in the feet. And then I'm going to start to work towards the knee. And in the bottom picture, I'm going to start to work to the pelvis. Now remember, I've already worked on the pelvis in supine. I palpated, this SI joint right here, and I use that flexion, abduction, external rotation on the right, the flexion, adduction, internal rotation on the left, and I'm releasing those areas. But the key word is I did it in flexion. Now we're in extension. So we're being really thorough with the SI joint. So my left hand in this case here is medial to the PSIS, and I'm doing a rotation with that leg. When that foot moves inwards, I'm closing the SI joint. When I move the foot outwards, I'm opening the SI joint. So I'm doing it in a circumduction, a screw movement, okay? In and out, in and out. So on their stomach, I'm releasing tension in the ankle, in the knee, in the hip, in the pelvis, all those areas, and I'm opening up the pelvic floor. Now, this is the important part. I'm going to start to work on the spine. The reason that this whole spine is going to melt away is because I've already opened up the bowstring first. Here's something I want you to be aware of. In the thoracic spine, there's also 3 joints, right? We have the cartilaginous joint, the disc in the front, and we have two facet joints. But I want you to pay attention here how the facet joints are like this. Remember, the cervical, we're like that. Facets are like this. So in the thoracic spine, we like to side bend a lot, maybe rotate a little bit. Now, because of this, I want you to pay attention as I do this. What I'm doing is I'm creating a movement with my right hand in this picture. I'm oscillating that sacrum left and right. And when I do that, you can see the connection here. First thing I do is I take the heel of my hand and I place it on these paraspinal muscles. I compress and I drag laterally, and I'm oscillating with my other hand. And what we're doing is we're stretching, we're starting at the top and we're working our way down, all the way down to the sacrum, mobilizing and stretching this. Then what I'm going to do is I'm going to hook with my fingers. I'm going to hook right here on the right side of the spinous process. And I'm still going to oscillate with that sacrum. As I begin to do that, this is moving side by side and it just melts away. These joints open up without any cavitation or manipulation. But the secret is I've opened up the front of the body first. I've opened up the bowstring first. That's why you have to do that before you do this. Okay, so that's crucial. The other thing is make sure as you're doing this, you're doing it very rhythmic. Okay, because everything you do has purpose. You have to do it at a certain rhythm because you're trying to calm them down, calm them down. Make sure the sensory hand and the motor hand are constantly connected and communicating at that feather barrier, and you're doing it in the proper rhythm. When you watch the videos, you'll be able to see that motion. It's like a dance. Okay. Now what I do is I grab the front of the shoulder. My right hand is sensory here, and I'm using the arm as a lever now. And I'm starting to mobilize the scapula. I'm stretching out the front, the influence at the front. Because remember, when I had them lying on the back and I'm pulling that arm forwards, I'm doing all those motions, I'm mobilizing everything at the back. Now I'm mobilizing things in the front. So we're treating both the front and the back of the legs, the arms, the head and neck, but also the whole torso. Okay. Then what do? We do the same thing to the left side. So I go into the left or the right side, the foot and ankle. We go into the knee, we go into the SI joint. We want balance. We want balance between both sides of the body. And then I start to oscillate with my left hand. My right hand is going to begin to fix these paraspinal muscles. I want to create a fixed point. My other hand's doing the oscillation back and forth. I want to stretch all that out. And then I'm going to hook in on this left side because I want these facets to glide back and forth. And the whole secret there is because we've opened up the bowstring. And this will just melt away. And if you're doing it in a very gentle, rhythmic way, you're going to calm that whole area down. And remember, as we work this thoracic spine, this is where the sympathetics exist, don't they? From T1 down to L2. We went over those. So you want to make sure that you loosen these areas up and you calm them down. So you have to make sure that you're doing this at a very specific rhythm. And then we do the other shoulder. Okay, we come in and we're opening that side up. Okay, now when the patient is on their stomach, the feet are off the edge of the bed. Typically, if I'm working on the left side of the patient's head will be to the left. Why do we do that? We do that to block that dural tube. Remember, it attaches to the foramen magnum. So if you're lying face down like this with your head to the left, I've created a fixed point. So all of these techniques are pulling up into the occiput, which is what? Where the fascia, the visceral starts. And I'm releasing all of that. Now, you're going to have some people that they can't tolerate having their head to the left. This lady couldn't. So that's why we have the face cradles. So you put them in a neutral position or put a pillow underneath their chest so their head can go to the left like that. Okay, that's important. If somebody has a lordotic curve and an arch like that, they're going to be compressing their lumbar spine, but also compressing here. Sometimes you see the pillow, you can put a pillow underneath their belly because you want to open things up. So that's just all kind of set up features. Let's talk about side lying. Now, side lying is in a wonderful position here, but I want you to pay attention again to the lumbar spine. In the lumbar spine, we still have those three joints. We have the cartilaginous joint in the front, that's your disc. We have two synovial joints at the back, but take a look at these facets. They're different. They're like this. They're in the sagittal plane. Thoracic, we're in the frontal plane. Okay, cervical, we're in the transverse plane. So the role of the cartilaginous joint is to absorb shock. The role of facets is to guide motion. So what motion is the lumbar spine going to do? Flexion, extension, right? Now I want you to think about this. If you had your patient lying face down, okay, let me go back a couple pictures. I want you to understand here that when they're lying face down and we're oscillating things side to side, you can see how these facets can move very easily. So prone is a great position to mobilize the thoracic spine, but it is not a good position for the lumbar spine. Because what's going to happen in the prone position, especially if you have a lordosis, you're going to block all these facets. So the lumbar spine does not open up with what we just did. This is why we have to lie you in a side lying position. In a side lying position, we're able to affect these different, lumbar facets. So we can start off with something really gentle like this, where I'm hooking my fingers on the left side. My thigh is in front of her knees, and I'm just doing a nice gentle oscillation. This is good for someone who's in a lot of pain and you're just trying to calm them down. Here, I have my sensory hand on my left hand, and I'm just doing a rotation from the top down. So this is nice, very gentle rhythmic motion just to open things up, okay? And in this bottom picture here, I'm doing the rotation from the bottom up using the pelvis as a lever. So I will do these as preparatory techniques, preparation. I will do these if someone is in a lot of pain, because this will start to open things up. This is what I want to do here. This is called the lateral roll, okay? And in this lateral roll, I want you to see that right here, I'm rotating, right, the trunk to the right, but I want you to notice that I'm pulling right here, the pelvis the other way, okay, to the left. And what does that do? That opens up these lumbar facets, which are in the sagittal plane. This is a great position, and we're always doing it at that feather barrier, okay? This is a progression here. This is me hooking on the leg, and I'm adding more force. This is not something you would start with. It's a progression. But what I like to do is be in this position, and I'll take this left leg and place it on top of this one and just kind of pull it forwards. This way it leaves my left hand free to palpate and my right arm free just to do one movement. So I'm creating a line of tension from her left shoulder to the right hip. I'm opening that up. Therapists put people in this position for manipulation. We're not focusing on the manipulation. We are focusing on lines of tension. Can you get a cavitation? Yes, but that's not our focus. Our focus is lines of tension to open this up. So we will start on the left side first, and then we do the same thing on the right side, opening it all up, okay? And then finally, we get to the seated position. Think of all the movements your spine does. It flexes and it extends. So in this position here, make sure that the patient is close to you. My left hand is my palpating hand, my sensory. Right hand is my motor hand. So the patient has her arms crossed, and I'm using her arms as a lever, and I'm able to work flexion, and I can go down the spine. In the bottom picture here, I can work extension. So again, I can do some fine tuning in the sitting position. And this will help a lot with the thoracic spine. Okay? The other movement I can do in this position is I can do rotation. So here I've got my right hand palpating, that's my sensory, left hand is motor, and I'm kind of doing this type of motion. I'm rotating to the left while my right hand, remember my sensory hand, my wedge hand can be passive or active. I like it to be active. So my right hand would be moving to the right while my left hand is rotating her to the left. And I would do these on either position. And because of the nature of the facets right here, we get a nice motion. Because we've opened up the bowstring, this is a nice way just to do some touch-up work at the end. Okay? I can also work side bending. Okay? I can side bend the patient. In this case here, I have my right hand as sensory, And I have my hand in front, and I can do work side bending all the way down. And you'll probably have an idea where you're working because we've already done this in the prone position, and you might have thought, this area is released, but there's still a little bit more. So you're always focused, where do I need to work on with this particular patient? I love this position. Now this works flexion extension as well, but I like this. You can face the patient. A woman, if you want, you can put a pillow on your chest. Make sure that you're higher than the patient. And as I slide in here, I'm working the upper thoracic. So I'm working that flexion and extension. I can also work a circumduction with all of this. In this bottom picture here I'm working the lower thoracic, but I could also have my hands up a bit higher and work mid thoracic. I love this one position. I use this all the time. It's a great way to finish it and just get any last little bits out. And then finally, this is a lumbar decompression. Is that patients in front of me, they're wrapped around. I come underneath the elbow. I'm using my legs and I'm lifting up, and it's a nice decompression to the spine. It's a great way to finish that. Now the curriculum, I told you the TBB1 is what we just did. So that's working in the supine position, releasing lines of tension in the legs, the arms, the head and neck, opening up the transverse diaphragms, opening up any fascia in the visceral, right? And then opening up that head and neck, you're opening up that bowstring. Phase 2, which is prone, now that's been done, you want to finish anything in the feet and the ankles, the knee, the hip. You're going to work your way up through the spine and then the shoulder girdle. You do the same to both sides. That will work the thoracic spine, but not the lumbar spine. So then we lie on the left side, then the right side. That will get the lumbar spine and also the ribs. That's also working the viscera, opening that up. And then we finish in a sitting position. Now, TBB2, it goes into more evaluations, but it focuses just on supine and prone. Let's say you have somebody that all they can do is lie on their back, and we will show you additional techniques to work on, problem areas. Or we can also work in the prone position. What you'll find is that after you've done this and you've opened things up, you can use TBB as a local treatment as well. You can be working on a knee or a shoulder or lumbar spine or cervical spine, and you'll be able to go after that joint in a multitude of different positions: supine, prone, okay? In level 3, we get into side lying in the seated position. So you'll find that the lines of tension are different in different positions, okay? Now, we also have an evaluation. So if evaluation is a difficulty for you, want to learn about it, we have all these for you as well. There is a core pack, and I think the D'Ambrogio Institute has sent you a flyer, and you have a significant savings because you're Canadian, right? And I'm Canadian, but also because we want to support this convention. This is my contact information. So if you want to get a hold of me, that's the website, the D'Ambrogio Institute. We have a YouTube channel there. That's my email address. So if you have any questions, and also if you're ever in Sarasota, Florida, if ever you Canadians are allowed back in this country, I think the number of Canadians coming down here is going to be reduced. We will be. So thank you very much. I'm going to stop sharing here. And if anyone has any questions, I'd be happy to answer them.
Hi, Kerry.
Hey, Scott.
Here we are. And do we have any questions for Kerry? Hold on, we're just looking at it right now. Kerry, I had one question. You had mentioned it before when you were talking about the one, not contraindication, but precaution that you should be aware of when working with older patients. What was that again?
Well, what happens with, if you look at the anatomy of the cervical spine, it looks like a saddle. So if there's a decrease in the disc height, water, the little tips of the sides there can come into contact with the segment above and below, and that's called the joint of von Luschka.
Can you say that again? Unfortunately, we just had some background noise. That's my fault.
It's called the joint of von Luschka. It's kind of a resultant joint. If you look at the, at the vertebrae of the cervical spine, it looks like a saddle. So the tips They can become more pronounced if you start to experience disc degenerative disease, and therefore it starts to come together. So you'll get a joint that forms. They call it the joint of von Luschka. So you'll notice a lot of elderly people don't side bend as much, so don't force it.
In this
The best
video,
thing
I'm going to walk
that really opens it up nicely, and then teasing out rotation. So these are all very safe to do, especially if someone has any vertebral artery, signs as well.
That's a great one. Hold on for 1 second. Oh, Kerry, one more. Well, I have a few questions. Typically, when you're doing this total body balancing treatment, how long does that treatment take?
Good question. Now, the first time you do it with someone, depending on your evaluation, it could take a while. I mean, I always give myself an hour the first time I'm with someone. That's evaluation and treatment. Subsequent visits, I only spend maybe a half an hour with someone. We were trained that we could do this in as little as 20 minutes. So it all depends. That's why you want to evaluate. You get a lay of the land. But here's another question that it's triggering a thought in my mind. This is called dosing, right? A better question would be, well, how much can a patient tolerate? For example, my father, who had congestive heart failure, he was in the hospital. I was happy to be up in Toronto to see him, and I was treating him in the hospital, but I only could treat him for 5 minutes at a time. That's all his body could handle. If I'm working with an elite athlete, I could probably work on them for 2 hours, and their physiology could handle it. If you're working, someone who's elderly and been through a lot, well, you may only be doing a 10-minute treatment. So you have an idea from your evaluation what's wrong, but John Warden would say, well, that's enough for today. We'll see how you do with that. So what I always tell people is start off and just do supine treatment with someone the first day and bring them back in a few days and see how they're doing. You might do supine again, because you think of the layers of an onion peeling away. And then after you've done it a few times, maybe you'll get them on their stomach and you'll do prone a few times. And then you'll gradually work your way into side lying and sitting. When people are learning, I say just learn one phase at a time until you're comfortable with it. Now, I have patients that come in just for a tune-up. I got people that come in once a month, every 2 weeks, every 2 months, and they want me to go through the whole thing because they feel better. They feel that when all the diaphragms are open, lines of tension are released, autonomic nervous system is calmed down, they're going to have health. Here's another question. What causes these barriers? All right. It can be trauma. It can be car accidents. It can be falls, sports injuries, but also what? Your emotion, your consciousness, your belief system will dictate your posture. So if something keeps coming back, could also be ergonomics. What are you doing with your body? That's why I always tell people, get pictures of yourself at your computer. Get pictures of yourself at work. I want to see how you watch TV. I want to know what you're sitting on. So all of these things can create lines of tension in the body. In my energetic balancing class, we get into downward causation, which means the consciousness, your beliefs, your emotions, right? All of these things that trickle down and can affect the physical body.
Oh, I've got a comment here from one of your biggest fans. You may know him, James Waslowski. He says you're a rock star. We had a couple, it's funny, you taught here last year in Burlington, Ontario, Canada.
Yeah.
To a really large crowd of massage therapists, and massage therapists are always interested like how to integrate what you're doing. And I think most of the work that you do can be integrated into what we do. But what I notice when you're working, and this came up from a few people, notice this, that when you're working as an osteopath, you have a lot of contact. You're using your body as a kind of to get motion, and using legs as levers. So there's a lot more kind of physical contact between you and the client. And as you know, it's like, people are just like, oh, I'm a massage therapist, but I don't really want to touch the client besides touching them with my hands, which is kind of funny. But how do you address that issue?
Well, I think it all comes, you have to take a look at what's the anatomy of a session, the intake. Why are they coming to see you? And a question I always ask somebody is, how are you going to measure the success of my treatment? And when I evaluate someone and I go through their body, I'm going to sit down and explain, your neck problem is coming from your legs. It's coming from these other areas. And I'll show them by lying them on the back. And then, like I told you about that story with that neck lady, is I'll evaluate their neck, it's stiff, and I'll get them to bend their knees. Look how much better that's moving. This is why we're going to do it. And then I'll treat those areas. So I get them to focus more on the outcome. What are they after? And as I'm doing it, I'll tell you what, if I've never been sued, I've never had sexual harassment or anything, because you're always professional. If I'm working with a woman, I might have the door open or might have my receptionist come in. I mean, you got to do the things to protect yourself. But I think people will know that if you're coming from a very sincere place, you explain things. I have acupuncture models all over, or not acupuncture dolls, but spines. I'm explaining things to people. I'm always explaining what I'm doing. Are you okay with this? This is what I'm trying to do. This is our end result. If you can get to that, if you can at the end of your session reevaluate and say, look how much better this is. I don't care what you did. They go, oh my God, I'm better. This is why I came here. So I think it's all about communication. Don't be afraid to treat, right? And you need to communicate. You guys are massage therapists. You're gifted manual therapists. Do your job. And I'm passionate about this because I've done this work for 30 years. I've treated over 30,000 patients. I've seen the people that fall through the cracks. I've seen those people that spend thousands of dollars that have failed surgeries, all those things that we talked about. They go from therapist and doctor to doctor, nobody's listening, and it devastates them. So that's why I teach. That's probably why a lot of the other people this weekend are teaching too, because they run into the same thing. We want to share this information. This total body package is so important. You should all be doing it, but it doesn't take away from what you're doing already. It just adds to it. You do both. After I do total body, then I go in and zoom in and do local stuff. Like James, we're going to do a class together. He does phenomenal local body stuff. So yeah, his stuff's amazing. Add it to the total body, whether you're doing acupuncture, strain, counter strain, muscle energy, myofascial, cranial, it all works together. All therapies work. The key is always the evaluation. Don't be afraid to treat, but explain what you're doing. And your body, when you're connecting with the patient, you want to use larger muscle groups because your hands should stay soft so you can palpate. You have your sensory hand, your motor hand, and you're feeling those rhythmic mobilizations. But explain to patients what you're doing. All they care about, they want to get better. They want to get back to work. They want to get back to their sport or whatever it is they do. That's what their focus is, and that's where you should keep your focus on. The treatment is a means to an end. So communication.
So really, what you've talked about from the very beginning is about doing a really good assessment, and then a treatment plan, a discussion with your client while they're there, and getting their informed consent before you even start treating them.
Yes,
correct?
Exactly. And I'll tell you what is I know a lot of you, obviously this is a massage conference, is bring them in with, tell them what to wear. I know Canada gets cold. I always have extra shorts here, t-shirts, I got gowns, right? So tell them what to wear and don't undress them. I know some of you are going to integrate massage with this, but get them with loose fitting clothes like yoga pants or track pants if it's cold, shorts, t-shirts, so that you can be more dynamic, so they don't feel uncomfortable. Go through all that stuff and say, you know what, now that we finish this, if you're going to do this, maybe you spend 20 minutes doing this and say, okay, let's get you undressed now. Let's do the massage. There's a couple of areas that I'm going to focus on from what we just did that we need to zoom in on. So you can integrate that local work with the total body work as a massage therapist.
That's a great point, because really what we're looking for as massage therapists is that before we even get our client on the table is that we have informed consent about what we're doing and areas that we're working on, sensitive areas where it's a gluteal area or the chest areas, getting informed consent or written consent from our clients. And really including them in that treatment plan will make you a lot more successful therapist, right?
Yeah, and if you are in a situation, I work on young kids, mothers in the room, or if she leaves, I leave the door open. Sometimes when you're working with kids, they can act out when their parents there. So I tell the mother, you know what, why don't you wait in the waiting room? I'm gonna have the door open. You can peek in anytime you want. So make sure you don't set yourself up for those situations.
Yes.
just, for me, it's common sense with that.
So when you, we actually had another question from Josephine Clements, and she asked, question, if this is an emotional causation with a client have emotional response, could that carry on well after their treatment?
Yes, definitely. Now, the question would be, well, why is that emotion there? For me, it's all post-traumatic stress disorder. There are things that happen to us all the time. But why is this there? Because of the magnitude of emotion that happened when you had a car accident or a fall or something, and they were united together. And so that emotion is there in the tissue, and you'll see it when you, as a massage therapist, when you go to work on someone's shoulder or their neck or their back, and you've done an incredible job and they feel better, but when they come back, it's the same story again and again. It could be either a total body effect, or there could be emotions or belief system. Your body, if we examine your body, the state that your body is in, I call it the total body lesion. It's based on every car accident you've ever had, every fall, your emotional trauma, everything. That's who you are, and you can feel it in the tissues. So sometimes I tell people that when you work on that, you can wake up a little something, where when the patient goes home, they can feel some different things, and that's okay. I said, allow it to come up. Don't stuff it. We're not psychotherapists. I work with different ones I'll refer, but I think you should know a little bit, observe, be supportive, answer the questions.
One thing I want to bring up is everybody was asking about the handouts you were referring to. If they actually go to below the screen on your presentation screen, they'll see all your handouts there that they can actually click on and download. Thank you very much for putting those there for us. Oh, I have a couple more questions.
Okay.
Actually from Alma, and she asks, I'm a petite 5 foot. How am I able to do a taller, heavier client?
It's funny. I have a few teaching assistants that are petite like that, and it's all, it's number one, having a high load table. All right. Or, if you don't have that, make sure your massage table is low for those particular people, because you want to have a mechanical advantage. I usually have these people. If you were at the conference last year, Jillian was my assistant. She's from Winnipeg, and she's this petite little thing. And I don't know if you remember, Scott, we had her treating this huge guy. Remember one of your friends?
Yes, my cousin
Todd. She did
Todd.
it perfectly. How'd she do it? It was just all body, using her body leverage.
Mm-hmm.
So, she just gently holds, but she, puts something on her shoulder or hip and then uses her body to do the motion. So there is ways that you can do that. But again, if you're working with if you're really petite and you got someone that big, then you need to get some help. You need to maybe refer to somebody outside. I don't want you hurting yourself. But there are ways of doing it with table height, getting the patient closer to you, hooking them into your body, and just using your legs. Everything should come from your legs to do that. But if they're too big from you, then you just got to make those decisions.
Well, during your presentation, unfortunately, we had a couple sound issues, but not in through Zoom, but through our platform. But I just wanted to let everybody know that's online. Of course, this presentation will be available for replay. It'll be a few days before I have it up for replay, because I just have to make some edits to it. Mm-hmm. But your presentation played perfectly through Zoom, so we won't have an issue with that. So when it's back up, we'll let everybody know in the next few days, and they'll be able to watch it again, because it's one of those presentations that you really do want to watch over and over again. And like I said, it's really, for me, it's really, and for the people, the other therapists that were there with me, friends of mine that I do exchanges with, I find that, thanks to you and thanks to therapists like Eric Dalton and James Wasowski, we all start our clients face up now, where we used to start them all face down. And it's such a huge difference in our success with client treatments now. So thank you very much for that.
That's a huge takeaway point, and hopefully you understand that.
Well, I want to thank you, Kerry. Your presentation was wonderful as usual. We always appreciate your contributions, and we hope you have a great rest of your day and enjoy that Florida weather.
Thank you very much from you, Scott and Monica, and then hopefully we do many of these, and everybody have a wonderful conference and stay safe. We'll see you next year, hopefully.
Thank you, Kerry. Have a great day. Cheers.
Cheers.